Good evening, ladies and gentlemen. Welcome to this webinar on obstetrics and COVID-19. My name is Hlombe Makuluma. I'm the medical legal advisor at EthiQal. I think some of you saw me last week when we decided not to address obstetrics or gynae questions. We will address those questions today. Just first things first, this webinar is CPD accredited. So you'll be able to earn at least one ethics point for attending. Just make sure that your MP number is correctly written. And those that did not register, you can send us your names, full name, your surname, your MP number at info@ethical.co.za. We also received a lot of questions during your registration, and thank you for that. We will address those questions as the presentation goes by or at the end of the presentation. But during the presentation themselves, just at the bottom of your screens, let me just have a look. There is something called Q&A, and that Q&A, you can write the questions that you would like addressed, and we will endeavor to, address all those questions. Let me not say we, let me just say, our presenters and the panelists will try their best to ensure that those questions are addressed within the constraints of time. Our presenters today are Dr. Ayanda Mbele. Ayanda is a director at GMG. We'll be addressing COVID-19 and obstetric care. And we also have Prof. Greta Dreyer. I really practice that one. Greta Dreyer. And she's the president of SASOG. And she'll be addressing the SASOG guidelines and talking around your PPE and non-emergency care. Without wasting a lot of our time, we might have some other questions that might be addressed, medical legal questions. Don't be afraid. We've got our friendly lawyer with us, so he will be able to address some of your questions. Every time that you get a phone call from a lawyer or get a letter from a lawyer, you get afraid. If that lawyer is known as JP Ellis, don't worry, he's on our side. So without wasting a lot of our time, I'll hand over to Ayanda to give us the first presentation. Dr. Mbele.
Thank you, Hlombe. Just gonna share my screen. Thank you, Hlombe, for your introduction. I would like to welcome this opportunity to present in this webinar. Good evening to everyone that is listening. This presentation will briefly discuss the epidemiology and the virology of COVID-19, and the rest of the presentation will mostly focus on the impact of COVID-19 in pregnancy. Ladies and gentlemen, the situation and information regarding COVID-19 in general is changing rapidly. Most importantly, the information regarding pregnancy care and outcomes remains limited. So the objective of this presentation is to summarize an approach to the management of pregnancy amid the COVID-19 pandemic using available evidence. The available evidence is limited to small case series, expert opinion, and guidelines from international societies. I will not be able to cover everything, but I will attempt to answer the most pertinent questions. COVID-19 is a zoonotic disease caused by the new strain of coronavirus, the SARS-CoV-2. The SARS-CoV-2 virus uses the spike proteins to gain access to the human cells by attaching to the ACE2 receptors in the respiratory tract, and then begins viral replication within the human cells. The ACE2 receptors are expressed by most organs in the human body, and the distribution of ACE2 receptors in the human body explains the resulting multi-organ failure in patients with high viremia with severe and critical disease. The SARS-CoV-2 virus was first identified in Wuhan City, China, towards the end of 2019. Since then, the disease has infected more than 5 million people and has led to more than 300,000 deaths worldwide. Globally, the USA has the highest infection rate and the mortality rate. In South Africa, there are more than 20,000 confirmed cases and more than 400 people have succumbed to the illness. The Western Cape has the highest infection and the case fatality rate. At present, it is limited data that describes the incident and the case fatality rate due to COVID-19 amongst pregnant women in our country. This slide demonstrates that in South Africa, so far, we have failed to contain the epidemic, but rather delayed its peak. Unlike in countries with contained epidemics, the number of daily new cases is rising. You can look at countries like Japan, South Korea, and New Zealand. In agreement with the recent data from the modeling experts, the worst is yet to come. So the obstetricians that provide an ongoing essential service should be prepared for the impending rise of COVID-19 cases in pregnancy. The clinical spectrum of COVID-19 in pregnancy is similar to non-pregnant patients and ranges from asymptomatic, mild flu-like illness to severe and critical phase with multi-organ failure requiring critical care. The disease severity has been categorized in an article published by WHO to be mild, severe, and critical. The World Health Organization and NICD recommend the diagnosis of SARS-CoV-2 infection by PCR on a nasopharyngeal swab specimen. A chest radiography is sufficient for the initial evaluation of pulmonary complications in most hospitalized patients. A single chest X-ray carries a very low fetal radiation dose, but a CT scan should be performed if indicated, as the fetal radiation dose for routine chest CT is low and is not associated with increased risk of fetal anomalies or pregnancy loss. Existing data demonstrate that a CT pulmonary angiography has a higher accuracy and is useful to exclude pulmonary embolism in these patients. Patients should be counseled regarding the risk of radiation and should be given an informed consent for the tests. Laboratory investigations tend to reveal a raised CRP and a lymphopenia, even in mild cases. Severe to critical cases can present with a raised D-dimer, low platelets, raised liver enzymes, and renal dysfunction. So it is important to note that these patients may have a biochemical picture similar to HELLP syndrome. An obstetric ultrasound and fetal monitoring should be conducted once the mother is stable. COVID-positive patients should have a dedicated ultrasound and a CTG machine to limit the spread of the infection. So given the maternal physiologic and immune function changes in pregnancy, pregnant individuals might face a greater risk of getting infected by SARS-CoV-2 and might have a more complicated clinical outcome. But according to Liu and co-workers, there is a lack of evidence that demonstrates the increased risk of infection compared to the general population. Available data from multiple small series generally suggest that pregnancy does not increase the risk of acquiring SARS-CoV-2 infection. Systemic reviews also show that pregnancy does not worsen the clinical course of COVID-19 compared to non-pregnant individuals of the same age. And the most infected mothers tend to recover with that even before undergoing delivery. The population most commonly affected by severe disease is older people, particularly those with comorbidities. Even though most pregnant women are younger than middle age, they may have comorbid conditions such as asthma, diabetes, and hypertension, which then increase their risk. Pregnant women should follow the same recommendation as non-pregnant people of avoiding exposure to the virus, such as social distancing, hand hygiene, disinfecting surfaces, and wearing a face mask in public. So to answer this question, should the antenatal care be altered during the COVID-19 pandemic? There is robust evidence that antenatal care improves pregnancy outcome, especially in high-risk patients. So in the midst of the pandemic, EthiQal and the SMFM recommends that antenatal care can be modified to decrease the exposure of the patients and reduce the workload of the healthcare workers. The number of clinic visits in low-risk women with uncomplicated pregnancy can be decreased and replaced by virtual visits using phone or video calls, as demonstrated in the figure. Women may be advised to check their blood pressure at home if possible, and appropriate advice should be given to them to seek assistance when necessary. The Health Professions Council has approved the use of telemedicine, and most medical aids will pay for those visits. So in order to minimize the risk of exposure of patients and healthcare workers, EthiQal recommends telephonic screening of patients for symptoms. Only those patients who screen negative should be allowed to present for scheduled antenatal visits. Those patients that screen positive and have a maternal or fetal reason to consult should be provided antenatal care with special precautions to minimize possible infection of clinicians, and should be offered a COVID-19 test. And those patients that screen positive but do not have an urgent obstetric reason to visit the clinic should defer the visit for 14 days. Special advice to monitor the deterioration of symptoms is also given to these patients while they're at home. Data collected in New York, where universal screening approach was adopted, demonstrated that out of 215 obstetric patients presenting for delivery, only 1.9% tested positive for COVID-19 were symptomatic. 13% who tested positive were asymptomatic, and 84% tested negative. So based on these results, the authors recommend universal screening in regions with the high prevalence of infection. And this approach is useful to guide hospital isolation practices, the use of PPE, and plan for intrapartum and postpartum care. So what is the management of suspected and confirmed cases? So the first consideration here is to discuss the place of care. These patients should be managed in a designated hospital or a separate ward. Suspected and probable cases should be treated in isolation until the test results are available. Confirmed asymptomatic or mild cases should be managed at home in self-quarantine if there is no obstetric indication for admission. Mild symptomatic cases with comorbidity such as diabetes, hypertension, and lung disease should be admitted and can be monitored for deterioration until they are symptom-free. Severe and critical ill confirmed cases should be admitted to a negative pressure isolation room in an ICU and be managed by a multidisciplinary team. All attending medical staff should wear appropriate PPE when providing care for suspected and confirmed cases. So the management of probable cases are those patients with COVID-19 symptoms, but the test results are inconclusive and are still waiting for the repeat of the test, and other viral infections have been excluded. Suspected cases are those patients that have symptoms, but the test results are still not available. We call this patient under investigation. These patients should be hospitalized in isolation for supportive management and monitoring for deterioration. Fetal monitoring is only initiated when the mother is stable and the fetus is viable. Further care of these patients is influenced by obstetric guidelines. So patients with confirmed mild disease are managed similar to suspected cases. Deterioration is monitored using vital data, and oxygen saturation is monitored using a pulse oximeter. Baseline blood tests should be conducted to monitor the hematological, renal, and hepatic dysfunction. These patients should be monitored and treated for secondary bacterial infection with broad-spectrum antibiotics if the procalcitonin level is raised. At present, there is no robust evidence that any therapeutic treatment is effective against SARS-CoV-2 in pregnant women. Studies are currently ongoing, and the results are promising, especially when immunotherapy is combined with antiviral agents in non-pregnant women. One study published in the Lancet recently demonstrated evidence of harm in the general population when hydroxychloroquine is used. It is important to note that pregnancy is an exclusion criteria for most of these trials that are still ongoing. So it's going to take a long time to develop guidelines for pregnant patients. So patients with severe and critical disease require ICU admission. Drawing from the data emanating from previous viral pandemics, severe pneumonia is associated with a high maternal and perinatal mortality rate. Therefore, aggressive treatment is required in these patients, which includes supportive measurements with hydration and oxygen therapy. These patients should be managed in a negative pressure isolation room in the ICU, preferably in the left lateral position or prone position, with the support of a multidisciplinary team comprising of obstetricians, intensivists, obstetric anesthetists, physicians, infection disease specialists, and virologists. Appropriate antibiotics treatment should be used promptly when there's suspected or confirmed secondary bacterial infection, following discussion with microbiologists. Blood pressure should be monitored and fluid balance should be carefully managed to avoid fluid overload. And supplemental oxygen should be used to maintain oxygen saturation equal or greater than 95%. Oxygen should be given promptly to patients with hypoxemia or having hypovolemic shock. And the method of ventilation should be according to the patient's condition and following guidance from the intensivist and obstetric anesthetist. Medically indicated preterm delivery should be considered by a team on a case-by-case basis for women with severe disease who are at least less than 32 weeks of pregnancy, but are beyond the threshold of viability. So a transfer to a center with a level 2 or level 3 neonatal ICU should be considered due to the increased risk of indicated preterm delivery in patients with critical disease. So delivery is indicated if it will improve the resuscitation of the patient. This algorithm demonstrates that hospitalized patients that are unable to maintain oxygen saturation above 95% with supplemental oxygen, and those with persistent hypovolemic shock despite treatment, and those with evidence of new end organ damage should be admitted in neonatal ICU in consultation with a multidisciplinary team. So what is the influence of COVID-19 on delivery? This slide shows an algorithm developed by Boelich and co-workers, and it has been adopted by the SASOG and EthiQal. It is a useful guide to triage patients presenting to labor ward. This algorithm shows that patients that have severe symptoms or have a contact with confirmed case of COVID-19 and have an acute obstetric concern should be admitted without delay in an isolated labor ward with a negative pressure for evaluation and management. The staff managing the patient should have appropriate PPE, and the COVID and influenza tests should be conducted in these patients. Patients with mild symptoms and have no acute obstetric concern should be directed to a drive-through testing lab and should be followed up by their provider and offered telehealth appointment. Patients that have a contact and no obstetric concern should be offered a virtual appointment and be followed up by their provider. So how should preterm labor be managed in these patients? These patients should be managed as patients under investigation because most of the time they present as an emergency, especially before 37 weeks. Research conducted in previous viral epidemics demonstrate that viral pneumonia in pregnant women is associated with increased risk of preterm birth, fetal growth restriction, and and high perinatal mortality. However, a small case series of COVID-19 positive pregnant women from Hong Kong demonstrated a slight increased risk of preterm birth, but there was no causal relationship between COVID-19 infection and preterm delivery. A similar study in the US found a slightly increased risk of a preterm delivery, but it was found that the preterm delivery was actually iatrogenic. In COVID-19 positive cases, earlier reports cautioned against the use of indomethacin due to the increased expression of AC2 receptors caused by NSAIDs. Recently, Poon contends that there's no evidence of worsening of COVID-19 morbidity when NSAIDs are used in these patients, but cautions against its use in severe and critical cases. According to EthiQal, in cases with preterm labor before 32 weeks with mild disease, steroids and indomethacin or nifedipine use should be discussed with the multidisciplinary team on a case-by-case basis in order to weigh the risk versus the benefits of tocolysis. Nifedipine is preferred over NSAIDs in this case, unless if there is maternal tachycardia. In severe cases, tocolysis and corticosteroids are contraindicated at any gestational age. Also, due to the risk of respiratory suppression, magnesium sulfate for neuroprotection of the fetus should be considered only in mild cases less than 32 weeks gestational age in consultation with a multidisciplinary team. So the timing and the mode of delivery should be individualized, dependent mainly on the clinical status of the patient, gestational age, and fetal condition. COVID-positive patients that are asymptomatic or have mild disease between 37 and 38 weeks, 6 days, should be managed expectantly until 14 days after a positive test or until 7 days after the onset of symptoms. Patients who test positive for COVID-19 after 39 weeks and are asymptomatic or have mild disease should be offered early delivery before the symptoms of the disease worsen. It is known that disease tends to worsen on average after 2 weeks after the initial symptoms. However, this decision is influenced by the capacity of the healthcare resources within each institution. Vaginal delivery is not contraindicated in confirmed COVID-19 patients. Shortening the second stage by operative vaginal delivery can be considered because active pushing while wearing a surgical mask may be difficult for the women to achieve. There should be a low threshold to expedite delivery when there is fetal distress, poor progress in labor, deterioration in maternal condition. COVID-19 infection is not an indication for a C-section unless a multidisciplinary team deems it necessary to improve maternal resuscitation. The use of nitrous oxide is not recommended due to the risk of aerosolization of the virus in the delivery room. Spinal anesthesia for C-section is recommended in a dedicated theater with negative pressure. In the postpartum period, breastfeeding is recommended. At present, there is no evidence of viral transmission through breast milk, but there's a risk of transmission through droplets from the mother to the neonate. So the mother should be advised to wear a mask and maintain good hand hygiene when breastfeeding. Grooming in is recommended for asymptomatic and mild cases, but the neonate should be kept at least 2 meters away from the mother. The Royal College of Obstetrics and Gynaecology recommends postpartum anticoagulation for all COVID-positive patients, but the Society of Maternal and Fetal Medicine recommends its use only for critical ill patients. Early discharge of patients is recommended when the mother is clinically stable. Advice regarding de-isolation at home is influenced by the disease severity, and all postpartum visits should be conducted remotely using technology where possible. So what is the impact of COVID-19 in pregnancy? At present, there is no evidence that pregnant women are more susceptible to COVID-19 infection and that those with COVID-19 are more prone to developing severe pneumonia. A systemic review by Poon and co-workers did not find robust evidence of increased maternal morbidity and mortality, and poor perinatal outcomes were also not demonstrated. In a systemic review, including up to 51 pregnant women with COVID-19, no cases of intrauterine vertical transmission have been documented. Most scholars argue that the low expression of ACE2 receptors on the placenta is a protective mechanism for the vertical transmission of the virus. So in conclusion, ladies and gentlemen, the COVID-19 pandemic poses significant clinical challenges for obstetric care. And this is compounded by the lack of robust evidence on the impact of COVID-19 in pregnancy. Research on therapeutic interventions is also limited. The information of COVID-19 is rapidly changing. The GMG and SASOG are publishing weekly updates in this regard. Even though COVID-19 infection in pregnancy has not been shown to increase maternal and perinatal mortality with the current data, the impending social economic challenges have a potential to negatively impact the maternal and perinatal outcomes in the next 6 to 12 months. We have a responsibility as clinicians to improve access to healthcare by providing affordable healthcare for all and be ready to join hands and assist the constrained public and private health system. The government has prepared the health system for the impending rise in cases. What have we done as clinicians in our practices? Did we create spare capacity for our care? I think we should do so. So this is a plea for all clinicians to redesign the business model in our practices amid the financial constraint that will face our patients in the next 6 to 12 months. The GMG may assist in this regard. This is also a call for collaboration and unity amongst clinicians in order to alleviate constrained human healthcare resources. In this way, clinicians that have comorbid conditions and they are above the age of 60 can reduce their risk of exposure to the disease through collaboration and teamwork. Also, this is a time for healthcare leaders and managers to strengthen relationships, be transparent, improve communication, and include clinicians when planning for the rise in COVID-19 cases. In this way, we will be stronger together in dealing with the pandemic. I thank you.
Thank you very much, Dr. Mbele. I think that was very informative, even to the non-clinicians in the group. There are a few questions that have been submitted, and we will address those questions after Prof's presentation. Can I hand over to Prof. Dreyer to give the presentation?
Good evening, Hlombe. Thank you for our introduction. I would also like to start my presentation by sincerely thanking EthiQal and Bettina for suggesting that we should have this meeting and webinar, for also suggesting that we should create a forum for discussion of the SASOG guidelines, and yourselves also for hosting it. Thank you very much. It's a privilege to be part of it. Question may arise, why should SASOG actually have guidelines? Because as all of you have seen, there are actually so many guidelines already trying to tell us how and where to handle this pandemic. And my opinion on this is that we do have a different country, we do have different challenges, and we are also in a different place in the pandemic. And therefore, I think it is essential. The other thing is it is useful to our members, and I think it can also, in many instances, really provide not only guidance, but also protection. So as a background, I just want to say that all obstetrics, contraception, all our emergencies, gender-based violence, cancer diagnosis and care, etc., is really a place where obs and gynae specialists are providing frontline essential services. And that, I think, places us right in the midst of this epidemic in our country. So I think specific safety principles are extremely important. We will talk about appropriate PPE. We'll talk about separating infected patients in order to make our healthcare facilities as safe as possible. And also then about how do we actually actively identify cases with possible disease. The general safety measures in medicine, in my view, should be much better than in other fields, and we should not lag behind, as we have often seen that actually happens, and with colleagues that don't really pay attention to these measures. Lastly, I think healthcare must continue as far as it can, actually continue the service so that we can utilize the available capacity, but it must only be done when it can be safe and when there is actually an indication. So in this presentation, I will pay attention to the protection of healthcare workers against this viral infection, pay attention to the prevention of nosocomial infection, where we actually have to protect our patients against the hospital, and also about, very shortly, because Ayanda has covered most of that, about how we manage patients with COVID-19. This is also in the SASOG guidelines in some summary. And then also lastly about, and I think this is very important for many of our colleagues, how do we actually proceed with some non-emergency O&G care during this epidemic? What are the principles, the prerequisites, and how do we move forward with this within guidelines and within not only economic, but ethical principles? So firstly, talking about the protection of ourselves. This is of utmost essence because we are most at risk, and we need protection also to prevent the loss of the essential workforce and loss of life. There are staff who is really at risk for severe disease, the older colleagues, and if you look at the specialists in South Africa, we have a very problematic epidemiology with very many older colleagues. And these people should actually not work in high-risk areas. All healthcare workers, of course, must wear appropriate full PPE in these areas. Then we should all wear masks at all times, and this is not only when we are in contact with patients, but also when we are in contact with communities, in the shops, etc., and still also when we are in contact with fellow staff members. It doesn't disappear the moment the people don't watch us. The threshold, in my view, for testing healthcare workers for COVID should be very low. And lastly, it is my view that treatment must be guaranteed for all healthcare workers who contract this disease. So what are the high-risk areas in obstetrics and gynecology? The point is that some areas in medicine have a higher risk for the transmission of airborne pathogens. And in our field, that includes vaginal deliveries, where the breathing of the mother actually causes that to be a very high risk area for transmission of the pathogen. Then general anesthetic, wherever intubation is going to happen or has a high chance of happening, that whole area should be covered as if intubation is planned. And lastly, where diagnostic swabbing is happening. So those places we need a dedicated theatre and delivery room for those actions, and these should then be allocated, as Ayanda has also pointed out, to both suspected or PUI patients and positive cases. Of note, we cannot use contaminated rooms for unconfirmed cases without terminal cleaning, and I think most of the hospitals have really come to the party there, and they have taken measures to make sure that their hospitals are quite safe. So what is full PPE, or what is full personal protection equipment for patients under investigation or patients testing positive for COVID in these high-risk areas? Now, we all know that hazmat suits are not available, and very few of us want to jump into those all the time. But there are alternatives available. Firstly, it's really important that patients should actually also wear surgical face masks as far as that is possible. And it is perfectly possible and easy to give patients also oxygen therapy underneath a surgical face mask if they tend to feel out of breath due to the mask. We also need to limit staff movement, and people looking after patients in this category should be dedicated to the area for the day if that is possible at all. And they should also wear full PPE. So if you do not have a water-resistant disposable gown, one can actually use a normal surgical gown with an apron for the delivery, for intubation, or for surgery. When there's no fluid really expected or present in the situation, the normal fabric gown without an apron is fine. The problem is that in that situation, if you do not have an apron, you should actually change your gown between patients because it comes into contact with the patient, and that is problematic. For patients in this category, the difference really between these patients and other patients that do not have a high-risk procedure is the mask. And in these situations, an N95 or FFP2 mask is essential or recommended and is the correct thing to do because airborne pathogens is a risk. The visor and goggles is really part of what we need to utilize when we are in contact with positive patients, even in lower risk situations as well. In my view, head and shoot covers are important because these are so easy to remove, and it's really much easier than having to change shoes and washing your hair and that sort of thing all the time. So I do think that is something that should not be omitted, even though some of the guidelines do not recommend. As I've said, then gloves and the apron should be changed between patients. So what about the lower risk areas where we do not have a high risk for the transmission of airborne pathogens, but we are looking after patients under investigation or positive patients? The only difference really here is that the surgeon or the medical staff should wear a surgical mask and visor and goggles, and you do not absolutely need an N95 mask. The rest is really identical. So moving then to how do we protect our patients from nosocomial infection, and when do we test patients and how do we manage that? Firstly, the general measures. I think we all need to understand and remember at all times that hospitals are absolute hotspots of infections, and precautions must be more vigilant than anywhere else. More vigilant than in factories, in shops, etc., etc. So we really are at very high risk to transmitting infection, also due to the nature of the people who live in the hospital, namely people being actually diseased already. It is therefore of absolute importance that patients under investigation, confirmed cases and negative cases must all be separated. Now this is the red, orange and green sort of zone idea. I think more than one hospital group has actually adopted that. The issue is that patients under investigation can never be handled as confirmed cases because they will then enter into a positive and high-risk situation while they might not have the disease yet. So you really need all three of these zones. Having said that, we all know that we will have unrecognized cases because patients can be asymptomatic and we can have false negative tests. There's also incubation periods, there's recovery times where the PCR test will be falsely negative. And that means that universal precautions against spread is essential in all healthcare facilities at all times and in all of these different zones. And testing patients, testing staff cannot replace that. So universal precautions is really, really the key to this management of this pandemic. Then the other issue is that susceptible patients, because they could contract the disease at the healthcare facilities, should be kept out of the hospital if the service is not essential or urgent. And I think here we are really all carrying a huge responsibility. And this includes older patients with non-urgent disease, etc. Secondly, everyone in healthcare facilities must permanently wear a mask. And I would like to say, not alternatively remain 2 meters away from other people, but actually we should combine both of these measures, because neither of the two is foolproof. So we will improve our safety if we can actually practice social distancing, although we all know that's quite difficult in a hospital. I think all of us need to take hands with the hospitals where we work, because we cannot withhold treatment from any patient because our facilities are unprepared. And if after 60 days of actually lockdown, we still have hospitals or areas that are not fully prepared for this epidemic, we really need to take responsibility and carry that responsibility with the hospital, because that it will just, that as it will not be a suitable excuse to say that we were not prepared and we were scared. So what about testing? We now said we have green, orange, and red zones, but how do we know in which zones to place patients? It is really probably essential for the safety of our healthcare facilities to screen and test all planned admissions. Now, the testing part is because screening is very, very far from super sensitive. So we can definitely have positive patients without any symptom. And those patients, although they will be transmitting hopefully lower numbers of viruses, will still be contagious. And that means that really, if you want a safe facility, you need to screen and test people before admission. Of course, there are a multitude of problems with this plan. The first problem is how long before the patient's admitted should you test the patient? The problem is how long will it take to have the results available? So if the turnaround time is long, you will have to test longer before. So whatever that interval is, we have to make sure that patients self-isolate from the time of swabbing to the time of admission. And patients need to self-attest that they have actually done that. The obstetric side of this coin is that we probably need to start testing patients at 38 weeks. And the big question is whether you should repeat that test 7 days later, whether you should repeat it every 2, 3, 5 days. And all of those options are really completely impractical and also unaffordable. So I would like to suggest that we repeat the test every week, once a week. And the question is, if the patient self-isolates from the moment of the first test, whether that actually can replace repeat testing. And the issue will be to actually sell that idea to hospital groups. Having said all that, we all have to know that we will have to accept that there is some false negative rate, and we will have to accept it. It's not high, and it will depend on how critical our epidemic is, but we will have to accept that we will not know in all cases, and that is where universal precautions come in. And then just a note on emergency patients who have, of course, to be tested at the time of their admission, and they are treated as patients under investigation until they have a test result. So we have quite a few remaining challenges in preventing nosocomial infection. One is, what do we do with undiagnosed positive staff members? We have non-nursing staff, we have staff working in several institutes, which is really not a great idea in this epidemic. And how do we handle that? We do have facilities who still have challenges with obtaining enough PPE. We have places where there's actually not really enough logistical space for separate areas and theatres, so that can be difficult to do. But we also have a difference in guidelines between different hospital groups, and we have seen hospital managers who actually abuse their power as well. And some of this, I think, is driven by fear. We also have an issue about who should pay for these non-medically indicated COVID tests. And here I think that we simply have to take hands and just do the tests, and whoever needs to be admitted will probably have to pay. When we have, I've talked about false negative tests, and then what do we do about emergency conditions in high-risk individuals? So we will have patients who are 65 years old, but who need an emergency laparotomy, and those will be problematic. And also, of course, atypical COVID disease. Just really one slide on the management of patients with COVID disease, and that is this one. I just want to say that we will, during this epidemic, we will be faced with patients who are possible COVID-19 patients due to a fever, respiratory distress, coughing, wet lungs, etc. Or they will have a septic shock type of picture, or other types of sepsis. And these are really typically diseases that we often see in obstetrics and gynecology. So I would say that we probably have even more potential COVID disease than in many other disciplines. And what do we do with these patients? And the big risk is that we actually suboptimally treat the real disease because we think that it's COVID. And I think the important thing is that we have to do simultaneous investigation and treatment for both diseases until we have a firm diagnosis. So in my view, the most probable alternative disease should be managed until we have proof of COVID positivity or negativity, or that the alternative disease is actually excluded or included. And that is critical if we do not want to have collateral damage in this area. Then really the mild, severe, and critical disease has been covered very well. I just think one other group of patients that should be treated as critical disease is when a patient with severe disease actually deteriorates under care. And those patients must also be admitted to ICU and handled as critically sick. This brings me to the last topic, which is really how do we as obstetricians, gynecologists continue with normal O&G care, non-COVID, non-obstetrics during the epidemic? What are the principles, the prerequisites, and what that should guide us? And maybe just looking at a few examples of disease that fall into these different categories. So the aim of ongoing medical care is really to prevent major backlogs in 6 months' time, to utilize our available capacity, which makes a lot of sense economically and medically, and then to prevent collateral morbidity, mortality. We then need to actually prioritize this type of decision according to how essential it is, how urgent it is, and also according to the individual's COVID risk. And we've already alluded to some of that regarding admission and safety of admission. Regarding the principles, we have to assess each individual condition and patient. Then we have to balance the benefit and risk of the different options, the different treatment options. In these days, we need to fully inform patients about the risk of being treated in a healthcare facility during the time of an epidemic. And we have to obtain extra consent for that because it is a new risk that we are not usually covering. We also need to carefully consider all the alternatives for inpatient care. And then lastly, I think we cannot really make rules without saying that these rules will change with time, because we have to have an ongoing assessment of the local situation, capacity, risk, etc. And what goes for Cape Town will not go for Pretoria at the moment. So this is really something that we all need to utilize our brains for, and we need to take a lot of trouble to take these decisions carefully and with our patients' best interests at heart. So what about consultations? As far as what should be ongoing and unlimited, really obviously all ONG emergencies, the assessment of potentially life-threatening disease. Here I'm thinking about a patient with postmenopausal bleeding, etc. All antenatal maternal care and fetal assessment. Ayanda has already talked about that. And then we have emergencies like early pregnancy complications as examples. But also, our president also even alluded to the fact that contraception, gender-based violence, really is part of what we need to take responsibility for and make sure that we don't have collateral damage in those areas. On the other hand, we need to consider limiting and postponing regular screening visits of totally healthy patients who really nothing will happen to them if they wait a bit longer. Low-risk benign or even malignant low-risk follow-up visits can potentially wait a few months. And then the low-risk antenatal, Ayanda has already talked about how we can potentially limit those sort of extra visits that are not essential. And then also consider to do some of it digitally or telephonically. So when should we actually do surgery? I think we should do emergency surgery, and I've defined that as unplanned, unscheduled, and you will find many different definitions for these different categories of surgeries in the literature, in the local literature, in surgical literature, etc. But to simplify, let's call it unplanned, unscheduled, but life and health preserving procedures, and they must obviously be unrestricted. Urgent surgery can include then semi-planned and unscheduled surgeries, and these should be done as soon as it's safe, and that should also not be restricted at all. With examples being severe ongoing pain, bleeding, or patients with infection and a non-response to antibiotics. When should we consider surgery, but think about it carefully? I think semi-urgent and semi-elective surgeries fall into this category, and I have tried to define them as important and time-sensitive ones for semi-urgent, but important and a bit less time-sensitive ones for the semi-elective surgeries. And in these situations, we should also then carefully consider the safety and whether the capacity at the hospitals actually allow for it, and we should give the patient a choice as well. And when she elects to have that surgery, that we should potentially continue and do it. The idea here is that you should consider whether postponement will cause a major loss of the therapeutic effect or not, and whether the morbidity of the condition warrants the risk of the surgical intervention during times of special risk in the hospital. But there are also conditions that we should really consider or just postpone surgery. Number one, if it's really non-urgent and it's totally elective, it's important, but hopefully not unindicated, because we should never do unindicated surgeries. But it's less, it's not a time-sensitive disease, and there are alternatives available in some of these patients. I would suggest that includes things like quality of life type surgeries, prophylactic surgery, and where the postponement really should be done until the COVID disease is finished, or one can actually explore alternatives to surgery. The other category is patients, where the patient herself is actually at a very high risk due to the nature of the procedure or the nature of the patient. So when you have ICU necessary, lengthy hospital stays, elderly and frail patient, and the risk is bigger than the benefit of the surgery, it is probably prudent to postpone that surgery as well. I would like to conclude by saying that we really have a responsibility to try and limit the damage done by this virus. by making sure that healthcare worker exposure, disease, morbidity, and mortality due to this disease is limited. We also have to try and limit collateral damage on our obs and gynae sexual reproductive health services, and we should try and make sure that there's no interruption of long-term service delivery as well. We also need to try and limit the collateral damage on non-COVID disease outcomes, and that includes things like cervical cancer, pregnancy care and outcomes, and many other diseases. And lastly, also consider potential collateral damage on social outcomes. So here I would like to include unwanted pregnancy and partner and domestic violence and sexually transmittable infections and diseases like those. I thank you.
Thank you very much, Prof. That's again, a very, very informative presentation. There have been questions that have already been submitted, and I would like to maybe first deal with those questions. And there are questions that have been submitted throughout your presentations. What I would like us to do, maybe we'll start with Ayanda so that Prof can take a glass of water. And you look at those questions, Ayanda, that you did not address during your presentation. And the request would be just to read out the question and try and give an answer if you can. I'm looking at the time, so would like to have really very short answers, but be as pointed as possible so that we can go through all these questions before we get cut off. Ayanda? You're on mute, Ayanda?
Sorry.
Yes.
Thank you, Hlombe. I've been answering a number of questions that were sent on this platform while they were coming up. I hope those ones I've addressed. But I see a common theme amongst the questions. I'm just going to group these questions into 4 themes. That's what is emerging. So the first theme is regarding the guidelines of the decisions that what I think. Let me just this is about the timing of induction of labor, the timing of delivery of the patients that are COVID positive. I think I've addressed that in the presentation, and then because the question here, the clinician is asking whether his testing approach of testing all patients at 37 weeks is advisable. During my presentation, I mentioned that the international societies recommend a screening. Even Prof mentioned that, I think, screening and testing all patients that are 38 weeks and above, and then if they are negative, they should self-isolate up until they go into labor. And then whether that test must be repeated after 7 days, it is unknown, but definitely in labor ward, that test should be repeated. There's a question also around delivery, whether should patients that present in labor be managed as PUIs. Yes, I think so. If the patient is not tested before coming to the hospital, they should be managed as PUIs until they have a negative test. Then another question that is that's common is the second stage of labor, an aerosol generating procedure. Potentially, yes, second stage of labor can be potentially aerosol generating, even though the patient has a mask, can still actually excrete some droplets that can be spread in the room. And also during the second stage, if the clinician has to use the assisted delivery, there's a potential for aerosolization of the COVID-19 virus. Therefore, clinicians are advised to wear full PPE, especially if the patient has not been tested for COVID-19 or if the patient has a PUI. And then the other question was, is it appropriate to offer induction of labor to all patients at the 39 weeks gestational age? Yes, patients that test COVID positive at 39 weeks have mild or still asymptomatic. The international societies recommend induction of those patients before they develop symptomatic disease. So, answer to that. Other common question was the risk of vertical transmission. I think I've covered that during the presentation. Another question from JP, not the ethical JP, was what are the guidelines of monitoring the fetus when the patient has got a critical illness, severe or critical illness? I think the fetus should only be managed once the mother is stable. And then the decision then to deliver will be actually be influenced by the possibility of improving resuscitation of the patient. So routine monitoring of the fetus before the mother is stable is not recommended. Another question, maybe I'll ask JP to help in this one. The question, I'm just gonna read this question that says, a hospital group in some town recommends that all persons under investigations may only be seen by a COVID team, and all NVD patients are treated as PUIs. So I think I've already answered that they'll be treated as PUIs if they have not been tested. Then this COVID team then manages all the patients, and then the attending doctor cannot attend the delivery. Only the COVID team sees these patients. There's a complaint that the clinician feels that this is incorrect and asks, who is responsible should there be adverse outcome of that patient? Before JP answers that question, I would like to say that the Society of Fetal Maternal Medicine recommend this approach, that we should start forming team. I think I mentioned in my presentation at the end that we should start collaborating so that we can have a group of clinicians that are exposed maybe for a certain week that are managing those patients, and these clinicians should alternate. So forming a team will reduce the exposure to the most valuable asset, which is the healthcare workers. I don't think this is a time to be worrying about income, because we're in the pandemic. We must be working together to improve the maternal outcomes and protect ourselves, most importantly. But the question then asks, who will take the medical legal responsibility for the undesirable outcome? I would like JP to come in there.
Yeah, that's before JP comes in. Just want to check if Prof have got a few questions that, the ones that we submitted earlier, or any other comment that she would like to make before we move on to JP.
I have 2 or 3 questions that I would like to cover and answer quickly. Shall I do that now, Hlombe?
Yes, please, Prof.
Okay. So the first thing that I see quite a few people are asking is, what PPEs are appropriate to use in your rooms when you consult? And theoretically, we are seeing asymptomatic healthy patients who pass through the screening and actually have a low risk to have COVID disease. And I don't think it's completely clear what PPE we need for that. The minimum criteria definitely includes a mask, and we do not need an N95 mask for this. But then you also need to have some protection between the patient and your own home clothes. So it's a good idea to use at least an apron. If you would like to use a gown, I think that is also very appropriate. Many people now work with scrubs, which you can very easily wash and remove even before going home, and I think that is appropriate, although it doesn't protect patients from each other. So I think the gown in that way is easier to clean between patients. And then I do think that in days coming, when our epidemic is going to actually increase, we should probably all start wearing face masks when we facial screens also when we are consulting. So a lot of this, as Ayanda and myself discussed before the webinar, is not actually based on hard science, but rather on good sense. There's one other question which I think I just want to allude to quickly, and that is, how do we handle this issue that we test patients, we don't have a test result, which means we have a lot of patients under investigation, which we actually need to isolate. And really, the only way to limit the number of patients under investigation is to make sure that we actually pre-test patients who are going to go into labor, that we have short turnaround times in our laboratories, something which we cannot control ourselves. And the other issue is that we need to address how these tests are actually being paid for. And I do think that we might not get a complete solution there. We are interacting with the medical aids, but I don't think that all of them have the ability to start paying for that. Which means that we will actually have to argue that the test result stands for longer, because retesting is really, I think, unaffordable for many patients. So that there again, my position is that patients who have self-isolated since the test should actually have a valid test result, should be seen as a valid test result. And I think we will take this up with the hospital groups as well. Thank you. I think that's all from my side.
Thank you very much, Prof. I would like to call on JP. JP has been seated there in the corner quietly. And I would just like JP to come on and just give just a few answers on the medical legal questions that were submitted. JP?
Thanks, Hlombe. I'll try and see if my video will work. It's been up lately. Firstly, thanks, Dr. Mbele and Professor Dreyer for the insightful talk. Just turning to the first question, medical responsibility. I see my connection's not working that well. Who bears the medical legal responsibility? Your ethical lawyer answer, it really depends. It depends on the nature of the claim, but still in particular circumstances. Typically in these type of scenarios, if it's something regarding the antenatal period, then typically the antenatal physician would bear that particular responsibility, whether it's something that was missed in the screening or whatever. With regard to the interpartum issue, that particular physician would then bear that medical legal responsibility, and that's sort of the general approach. There were a few other questions. One particular question was aimed at whether or not
Yeah, we're struggling to get JP clear.
I apologize. So there's another question about whether COVID-19 could qualify as an injury on duty, and if a practitioner COVID-19 qualify as a...
Yeah, I think JP, we just have problems in really hearing exactly what you say. I think if you can try again, if not, then I will take some of those questions.
Sure, okay, again. So the answer to the first question, okay.
Now, let me try and address some of the questions, JP. I can see a message here saying that your bandwidth is low. So let me try some of those questions. I think the question that JP was dealing with is a question around whether can you take, just want to check because those questions are in front of me, whether can you take as an injury on duty. I'm not sure, JP, and I don't want to give a wrong answer here, but common sense will tell me that, as you go into work, you'd always be covered by the labor laws. That is, your employer has to make sure that actually the environment you're working at is safe, for all the kinds of work that you do. It is the employer's responsibility. Now, if you are running your own private practice, it's an important thing that you ensure that you protect using the best available information in terms of the screens that are actually there, maybe at your reception, and also whoever is going to be in contact with the patient. You make sure that the screening is there, the social distance is kept at bay, so that your own employees actually are not infected. At the hospital where we work, that's exactly what the hospitals should also be doing, to make sure that if you get into a theater, you get into a ward that, this is not your ward, this is a hospital's ward, you make sure that the employer themselves are supposed to put in exactly all the measures that are supposed to be put in to ensure that there is no transmission of the infection is minimized. If you happen then to get infected, I think it's an important thing. I mean, the lawyers will say it, that then there's a need to prove actually that the minimum standard was not met or there was negligence on the side of the employer. I think there could be a case, but what is important is to protect our employees, is to protect ourselves, is to protect our patients. There was a question around also the scope of practice. I think the scope of practice has been addressed on many forums, and therefore it is an important thing that when it comes to the scope of practice, I think the HPCSA has defined an emergency. It has to be clear that you will be covered under the scope of practice if you practice beyond your scope. However, in practicing beyond your scope, it's important to make sure that you also understand your own competence. Because imagine a dermatologist trying to do a cesarean section. So those are some of the things that are very important. You are better off by saying that I am not competent, and therefore I am not going to get myself into a position where I will do more damage to the patient than actually I can be able to based on my own competence. So those are some of the important things. Now, the question there comes that says, is it going to be, are you covered for that? It's a very clear thing that you will be covered if, for instance, you are an obstetrician that has not practiced for some time, or you are registered only to gynae, and then there's an obstetric emergency. You will be covered for that. But you will not be covered if you're going to try and do something that is a very clear thing that you are unable to perform. For instance, you want to do a tracheotomy. If you know for sure that you cannot do this, and whatever you do is going to cause more damage to the patient, rather you say that you will do the best you can without actually causing more harm to the patient. Any other comment maybe from Prof and Ayanda? I'm just looking at the time so that we don't stretch the meeting beyond what is actually
There's a question, Hlombe?
Yes.
There's a question on running out of PPEs, or
Yes.
People saying, well, if all patients or so many patients are managed as patients under investigation, how do we handle the scarcity of PPEs? And I would like to just argue that surgical gowns, washable, are not actually scarce. They just need to be washed. Plastic aprons are actually not scarce. We have a lot of very cheap head covers, and we can all use reusable and washable head covers as well. And actually, foot covers or shoe covers are also not scarce. The only thing that really is very scarce is the disposable gowns, which are non-essential, and then N95 masks. Now, patients under investigation who are in labor need to be managed with N95 masks, but those can be safely reused after 4 days of waiting. So you can simply place your mask in an envelope, wait 4 days, and then reuse it. And there's also methods to actually sterilize those masks that have been demonstrated to be safe. So I do not think that PPEs will necessarily be a big obstacle. Thank you.
Thank you. I got the answer from JP in terms of COVID-19, whether it qualifies as an occupational health and safe under the Occupational Health and Safety Act. And JP says, yes, it qualifies. Typical lawyer, he says Section 8 and Section 9 of the Act. It's relevant here. So it qualifies. What we'd also do is we'll just take some of those questions that JP didn't really answer because of the connectivity, and we'll just send them all to everybody so that we can have a comprehensive answer on those questions. I'm looking at the time. Unless there's really some burning other matter that we need to discuss, I would like to thank our presenters, or maybe I should just give them, Ayanda and Prof, just one last word, if any, and then we close the meeting. Anything from your side, Ayanda, as the last word?
Yeah, I think, as I said, this is a time to work together, to form teams in order to provide an effective, efficient service for all. And then we can be able to protect the valuable healthcare resource, which is human health workers, by not exposing everyone, to patients that are exposed. We can limit that exposure by working together. Thank you.
Thanks. Prof?
From my side, thank you again for the opportunity. I also want to invite all the participants, if they have specific questions or problems, to interact with SASOG. It can be done via the Secretariat or directly to myself, and we will try to address your concerns as best we can. Many thanks.
Thank you. I'd like to thank both of you, our presenters. JP, would like to thank Joe, who really is keeping us onto the narrow line here to make sure that we behave appropriately under the Zoom technology. And all of you as the attendees in this meetings, I think this is the future, and would like to continue having these webinars in a much more even structured manner. So from an ethical point of view, any of you who's got certain topics that you also want us to discuss, please send them through to us at info@ethical.co.za. Then we'll see if we can get other speakers or other seminars like these ones. But this has been a very, very valuable interaction, and we think that we're going to continue doing it going forward. Without wasting a lot of your time, I know dinner is ready. Thank you very much.